penultimate topic for today will be expert consensus and recommendation from European Society of Intensive Care Medicine. This is regarding the basic ultrasound head-to-toe skills for intensivists practicing in general and neuro-intensive care population. As we all know, Alhamdulillah, the use of ultrasound over the past 3 decades has quite advanced. On the right-hand corner, you can see Dr. Theodore Tasek using the first demonstrated ultrasound machine, a very heavy, a very immobile machine. And on the lower end, you are seeing the ultrasound machine. They are using water as a conductor for the ultrasound here. And Alhamdulillah, over years we have progressed to bedside ultrasound machine, now the portable one. And now, Alhamdulillah, we have the handheld ultrasound machine. We can just carry it in our pockets. From the cardiologist, from the radiologist, Alhamdulillah, the use of ultrasound has been diversified. Now it's the hands of our intensive staff. So we have started using ultrasound right from the 1990s. We just started using it for procedures like insertion of lines, ventral lines, arterial lines, and from then on we had moved for protocolarized diagnostic evaluation like e-fast and fast examinations, and then later from 2010 onward for the nuanced pathologies, all of us should know Dr. Daniel Jensen, who had a great work on the lung ultrasound, wherein he could diagnose certain pathologies like A lines, the V lines, using the artifacts for the diagnostic assays. And from then on, there was a worldwide movement which increased the use of ultrasound and got critical care ultrasound into the world picture. Then we have progressed towards using iterative cross-sectional evaluation, wherein we can evaluation A lines, B lines to differentiate different types of aeration disorders, diagnosis of pneumonias, collapses, pulmonary embolism, going into a blue protocol, and recently vascular excess, the venous excess cascade, where we see the IVC, the venous system comprising of the hepatic veins, the renal veins, and to get into offer a more restrictive, fluid restrictive and fluid restrictive strategies. And finally, we also hemodynamics monitoring. They are using the VTIs and even the transesophageal echoes. So all of us, Alhamdulillah, are somehow or the other involved. We have recognized, we have been practicing intensive care all along. You know, some of us are at different levels. We have all got trained. We all have got trained into various specialties. We have read, we have undergone training, everything. But however, most of us, if you all agree, we are just restricting ourselves to using ultrasound for invasive lines, insertions, and just for assessment of cardiac output or the IVC diameter, and we are not gone beyond this. So there are certain barriers which we saw, because once we come back to our clinical practice bedside, there are lack of trainers, there is lack of ultrasound formal curriculum, there are a lot of train constraints for the bedside rounds, and there is also resistance from the colleagues inside and outside, causing, and there is sometimes lack of equipment, one ultrasound machine shared by many departments. And finally, all of this gives rise to lack of training among the trainees, lack of interest among the trainees, and perceived lack of utility. So to overcome all of this, it was in 2009, the basis of the scope of critical care unit ultrasound was found around the world. It was by American College of Chest Physicians and the French Society. We offered a document wherein they described what critical care ultrasound is. They divided critical care ultrasound into echocardiography and thoracic, abdominal, and vascular ultrasound. But however, the competencies remained to be low for so many years, and it took almost another decade, 20 to 21. The European Society has issued the new
expert recommendation. There is no guideline, this is just an expert recommendation. I would like you to remember. The purpose of this guideline is to provide consensus and a list of expert recommendations regarding basic skills of head-to-toe ultrasonography in intensive care setting. This consensus provides guidance for basic use of critical care ultrasound and paves the way for development of training and research projects. So this is just a comparison between the American College of Chest Physicians guideline and the 2021 guidelines, where we need to identify certain clinical syndromes in each different organ systems, and we need to know what skills we need to acquire to get a diagnosis and to manage those systems, and any interventions we can do, like for instance, paracardiocentesis, paracentesis, invasive lines and procedures. The only difference between the 2009 ACCP guideline and the 2021 guideline is they have introduced diaphragm dysfunction assessment and brain ultrasound into the 2021 curriculum. That's the only difference. Just starting with the ultrasound, there are around 74 recommendations. I cannot go into all of this. I'll try to summarize most of them. Starting from the transcranial Doppler ultrasound, we all know there are 3 areas where we can have a window for the brain. One is the temporal fossa, the thinnest part of the bone, where we can access the brain parenchyma from, where we can we have the optal we can use it as the optic nerve sheath diameter, keeping the probe on the eyeball, and we have the suboccipital approach. So there are many conditions which we may be able to identify, diagnose using transcranial ultrasound. We can diagnose intracranial hemorrhages, intraventricular hemorrhages, midline shifts. We can use it, we can assess the various vasculatures. You can use the Doppler assay to assess the vessels, the middle cerebral artery, the corona, the circle of Willis, wherein we can find or triage patients to find whether these patients are prone or can have developed intracranial hypertension. Based on this transducer pathologies, we can even assess whether this patient are prone or have cerebral vasospasms in cases of subarachnoid hemorrhages, to know the flow velocities and the decrease in the diastolic velocities in assessing a patient with decreased cerebral perfusion, as in case of a diagnosis of cerebral brain death, so on and so forth. However, they recommend as a basic ultrasound, all of us only to interrogate, to use the transcranial assessment only to interrogate the middle cerebral artery, to know, to calculate what we call as the pulsatility index. So the basic ultrasound, if you have to learn for transthoracic, it's only interrogating the middle cerebral artery to find the pulsatility index, so that we can triage the patient based on the index, whether the patient have a suspicion of intracranial hypertension. Clinical suspicion of brain death using ultrasound, using it as a diagnostic tool for the vasospasm in subarachnoid hemorrhage, evaluation of stroke, intracranial use of intracranial pathology, and all are not recommended. They are not recommended. Not recommended doesn't mean we should not acquire the skill. However, they say you need advanced training in this pathology. Cerebral autoregulation is changes in cerebral autoregulation in cases of hypotension, in hypervolemia, in hypocapnia, hypoxia. How does the cerebral vessel velocity change? It's also not recommended. Coming to the important lung ultrasound, it has been suggested that you divide the lung into six quadrants, drawing a line from the sternal area to the anterior axillary line, then to the posterior axillary line. So 1, 2, and the third segments, each dividing into superior and inferior segments, and you interrogate these segments bilaterally for lung pathologies. So the common lung pathologies are what we need to know is pneumothorax, identifying pleural effusions, and lung aeration disorders. Coming to the pneumothorax, all of us should know to identify the lung sliding, absence of lung sliding, then a lung point, which is pathognomonic of diagnosing a pneumothorax. And you can even quantitate like in a spontaneously breathing patients, you can quantitate the amount of pneumothorax present on the chest, and you can make a marking of it. So mainly, if you find a B line with a sliding line, that will negate. That's a sign that there is no pneumothorax. However, the absence of lung sliding and the presence of especially of the lung point is pathognomonic of a pneumothorax. For the pleural effusions, you need to see the hypoechoic. You need to diagnose pleural effusions as a basic skill. The hypoechoic clear fluid, or you have the septated anechoic segments, a complicated pleural effusion. And even for you to calculate the volume, there are various formulas. What is mentioned is called the Balick formula, where from the diaphragm to the lung, the normal lung parenchyma, you measure the distance and you multiply by 20 just to estimate the volume. As a basic ultrasound skill, we also need to know for the fluorosynthesis, it should be ultrasound guided, and even post fluorosynthesis, just if you have the adequate, to check whether the adequate drainage you have attained or not, you need to use the ultrasound. Sorry. Okay, then finally, moving to the aeration pathologies, differentiating interstitial lung syndromes, finding B lines, the amount of B lines is a basic requirement, and diagnosis of a pneumonia, wherein you will find, normally you will not find any tissue-like structure with lung ultrasound. If you find a tissue similar to the liver on the lung ultrasound, having the red markings, what you're seeing are the aerobronchograms, pleural effusions, and this is the pleural sign. This is called as a shred sign, wherein the underlying lung beneath the pleura will have a fractured appearance, unlike a smooth appearance in case where you have an interstitial lung syndrome like pulmonary edema. So these are all considered to be basics. We as intensivists should know. Coming to the airway ultrasound, it is not recommended. It is, however, the recommendation is against to use ultrasound for confirmation of endotracheal tube placement. We have the diaphragmatic ultrasound, wherein we can assess the patient for weaning from mechanical ventilation. There are two methods to one method is to just see the excursion of the diaphragm in various maneuvers, like in a tidal ventilation, in a cough, and in a sniff ventilation, and there are various values for it which we can use to assess the patients for weaning. However, this should be done only on a spontaneous breathing patient. However, as an advanced version, which they don't recommend, is using the fractional contraction of the diaphragm, where we can use in patient for on a patient who is having ARDS, on say who has been sedated, ventilated, who's been on controlled ventilation also, to assess, because the difference in the contraction is a few millimeter. So it needs advanced training to get into these subtle details. Coming to the heart, it's important for us to evaluate for another 5 things here to know for LV failure, RV failure, to know hemodynamically important pleural pericardial effusions, to know the LV left ventricular valve pathologies, and to for assessment of hypovolemia. This is one of the important thing. For instance, for the evaluation of left ventricular systolic failure, there are various methods, as we all know. Our active technicians use the Simpson method, or you have the MAPSAFE, or various methods. But for us, as a basic thing, eyeballing is good enough. Okay, you can classify just based on eyeballing. But the number is not important. If it's more than 55, 50, 60, you can just say that the patient is the LV is well contracted. It's normal. It is moderate. The LV function is moderately reduced, severely reduced, or the LV is hyperkinetic. Okay, so you can just assess based on the LV. The other important thing is to know for any regional wall motion abnormalities, especially when the troponins are borderline, and the ECG changes are settled and non-ST elevations. MI, just to rule out any cardiac cause, we need to know the regional wall motion abnormalities. Is the cardiac dysfunction global or is it regional? It is also recommended that we know how to calculate the stroke volume. The stroke volume based on if you have the parasternal long axis value, where you can assess the RV outlet, the aortic diameter, where we can calculate the radius, and with the aortic 5-chamber view, you can get the VTI, wherein we can calculate based on the formula pi r square h, where we can get the radius here and the volume, the height here, pi r square h formula. You can calculate the cardiac output, and if you can multiply with the heart rate, you will get the cardiac output. So the stroke volume times the heart rate will be the cardiac output. So TE is not recommended as a basic skill. Evaluation of right ventricular failure, especially when you are suspecting pulmonary embolism, knowing the size of the LV to RV ratio, the signs of RV failure, like in terms of a dilated RV, flattened interventricular system, the McConnell sign, they are all considered as basic. However, we need to differentiate between pulmonary embolism and maybe some other concomitant pathology. So just don't look at the RV, concomitantly look at the LV as well, and look at the IVC as well. If the RA, LV both are dilated in a situation, think like the patient has lung pneumonia, ARDS, it could be secondary to the lung parenchymal disease, not the vascular disease. If all the 4 chambers are dilated along with the RV, it could be a biventricular failure, which we are having. And it's important that many of the patients, what we encounter is the patient will have, any patient with hypotensive, when we evaluate, the patient can have a pericardial effusion. However, knowing whether this pericardial effusion is contributing or would have a tamponade physiology is important. So clinically, you have to assess the patient first. And secondly, to know if the patient has this pericardial effusion, which is leading to cardiac tamponade, you need to assess a lot of things, just not just being the fluid or blood present in the pericardial space doesn't say that the patient is in cardiac tamponade. So usually the size, if it's the size doesn't matter if it's an acute thing, but however, you should know whether it is circumferential or loculated, and whether RA systolic collapse in more than 1/3 of the cycle is occurring. You have RV diastolic collapse, and you have IVC, which is usually dilated. And very important thing is also to know the flow reversal. The pulsus paradox, echo pulsus paradox, wherein you will have on inspiration increase inflows in the right ventricle by 40%, and then through the mitral, across the mitral valve by 25%. You should take all of this into account, and these are all considered as basic requirement for echo. For hypovolemia, knowing we all go by the kissing heart, the walls kissing, but also we need to calculate the end diastolic diameter. In a true hypovolemia, the end diastolic volume, the end diastolic area will really be low, as in a pseudo or a vasodilatory shock, wherein you will have the end diastolic area will be almost normal. And the last component of valve compliance is to know whether you have you should diagnose the valvular lesions like severe AR, severe MR. It could be you're dealing by, you might, so identifying severe devastating complications like an acute AR, acute MR is part of the basic skill for an intensivist. Coming just penultimate to the abdomen. Abdomen is a Pandora box. It has a lot of limitations in use, because in any acute abdomen, you will have gaseous distension will obscure the findings. The issue with the abdomen here is, abdominal pathologies like intestinal obstructions, leaks, perforations, and you cannot diagnose it. So the basic, what we need to know by a basic ultrasound when we do a basic POCUS ultrasound as an intensive in the abdomen is to find out free fluid, to get to know whether there is any free fluid. In the case of cirrhotic patient, with acute abdomen, thinking of SPP, just to know whether the patient has any free fluid in the abdomen. Especially if the patient has come back from any procedures deteriorating, like for instance, the patient has come back after a renal pathology, after some liver biopsy or something, the patient deteriorates, put an ultrasound on the abdomen and check whether there is any hyperechoic, any fluid there. And for the traumatic abdomen, we all know the EFAST. I will not elaborate on it, where you will have the pericardial effusion, the pelvic fluid, the fluid in the Morrison's pouch. And this is, you need to do any change in the patient's clinical condition after procedures. So what happens is, like for instance, if a patient has come back from a renal ultrasound or anything, from a renal biopsy, the patient is deteriorating, you just do an ultrasound, or a hepatic biopsy, the patient comes deteriorating, you put the probe and you just see there is a fluid dense area and there is a fluid. This is the fluid, the hyperechoic area, and this is a hypoechoic area. So likely this is the cause of the deterioration, the hemodynamic instability. There's an acute hemoperitoneum. This sign is called as hematocrit sign. Okay. And the other pathologies we need to know on the ultrasound abdomen is to diagnose an aortic syndrome, like abdominal aortic aneurysm. Just you have to scan through the epigastrium to the umbilicus to see in the longitudinal and transverse sections to see if there is any aortic aneurysm, and in diagnosis of hydronephrosis. Lastly, coming to the vessels, it is recommended that before you insert the central lines, you assess the caliber of the vessel to rule out any obstruction, to rule out any thrombus. You can just do a compression study and you can see the length of the vessel which you can access. And always use an ultraside guidance, not an assisted approach, meaning to say you need to always have a track of the needle, whether you are using the longitudinal approach or a transverse out of plane approach, you need to track the needle always. And as regarding it's also recommended that if you have a difficult arterial cannulation or failed arterial cannulation, you can use ultrasound for an arterial cannulation as well. And especially after you have finished the invasive procedures like central line insertion, see to it that no complication has occurred. You need to see again for any pneumothorax. Just if you place the lines across the neck, just check for any pleural sliding or something underneath and have a follow-up on it. And look for any, if you have punctured the femoral areas, for any hematomas and other things. For deep vein thrombosis, you need to assess the vasculature from the groin down to the popliteum, and they recommend using compression ultrasound. So the take-home message is critical care ultrasound and ultrasonography is an evolving skill in critically ill patients, which is considered as standard of care. Hence, it is a fundamental skill and competency which has to be acquired over a period of time, which includes gaining knowledge in the basic principle governing ultrasound, the knobology, bettering image acquisition, interpretation, and follow through first go through the basic skills, and then over a period you can get into the advanced courses. And this all needs new educational techniques to overcome barriers and to help us to bridge the gap in critical care ultrasound in the coming years. Thank you.